and today I will be taking an introductory class on ischemic heart disease. Exactly what is known as ischemic heart disease, its pathogenesis, and a few words about angina. So ischemic heart disease, it represents a group of pathophysiologically related syndromes resulting from myocardial ischemia. Now, what exactly is ischemia? Ischemia is when the blood flow to a part is interrupted and there is no blood supply to it. And this occurs due to an imbalance between myocardial supply and cardiac demand for the oxygenated blood. Now, what are the consequences of ischemia? Ischemia limits tissue oxygenation so that ATP generation is reduced. It reduces the availability of nutrients like glycogen, which are needed for the energy supply, and the removal of the metabolic waste is hindered. So, simple hypoxia is usually well tolerated than ischemia because in hypoxemia the blood supply is not hindered. So, there is availability of nutrients and removal of waste, metabolic waste can occur. So, the hypoxia which occurs with severe anemia, cyanotic heart disease or advanced lung disease is usually very well tolerated. Now, the dominant cause of ischemic heart disease is insufficient coronary perfusion relative to the myocardial demand. Now, in more than 90% cases, this is due to progressive atherosclerotic narrowing of the epicardial arteries and variable degrees of superimposed plaque change and thrombosis. Now, in this you can see there is a fixed atherosclerotic plaque. When it ruptures, then the platelets in the circulation come in contact with the subendocardial collagen, which may lead to healing and a progressively smaller lumen, or there may be coagulation and thrombus formation, and it may lead to complete occlusion of the lumen by the thrombus. Now, the other causes can be the coronary emboli, vessel inflammation and vascular spasm. Now, most probably increased cardiac demand in setting of modest vascular occlusion, that is, it may be tachycardia, cardiac hypertrophy, hypoxemia or systemic hypertension, which leads to ischemic heart syndrome. Now, in 90% cases, IHD has atherosclerosis involving one or more of the epicardial arteries, so it is also known as the coronary artery disease. Now, what exactly is epicardial artery? Epicardial artery is the portion of the coronary arteries which are on the surface of the heart. As soon as it penetrates the muscle of the heart, it becomes a penetrating myometrial artery, which are generally not involved in atherosclerosis. Now, the clinical manifestations of coronary atherosclerosis are generally due to progressive narrowing of the lumen leading to stenosis or to acute plaque erosion or rupture or thrombus formation, all of which eventually compromise the blood flow. Now, the vessels involved may be 1, 2 or all the 3 major epicardial arteries, usually within the first several centimeters, and can be located anywhere along the course, especially in the right coronary artery, and atherosclerosis of the intramural branches is rare. Now, what are the consequences of MI? It can present as angina, it can present as myocardial infarction, sudden cardiac death, or it may be a prolonged phenomenon with chronic ischemic heart disease with heart failure. Now, Angina Pectoris, it is characterized by paroxysmal, that is, occurs in periods. It is usually recurrent attacks of substernal or precordial chest discomfort caused by a transient ischemia. Ischemia is less than of 15 minutes, but is insufficient to induce myocyte necrosis. But there is pain. So, why there is pain without necrosis? This pain is due to the ischemia-induced release of bradykinin. Necrosis is due to the ischemia-induced release of bradykinin, adenosine and molecules that stimulate the sympathetic and vagal afferent nerves. Now, patterns of angina pectoris. It may be a stable or typical angina, prismatic and unstable or crescendo angina. Now, the most common form is the stable angina, and it is caused by decreased coronary perfusion due to a stenosing coronary atherosclerosis relative to the myocardial demand. Now, when does myocardial demand increases? It increases in increased physical activity, emotional excitement and psychological stress. Pain is deep, poorly localized and squeezing or burning type, and it is relieved by rest, so that demand is decreased, and by administering vasodilators like nitroglycerin and calcium channel blockers. Now, prismatic angina, it is an uncommon form, it is an episodic form, and it is caused by coronary artery spasm. So, the attacks are unrelated to physical activity, heart rate or blood pressure, and it responds promptly to vasodilators. Now, the unstable or the crescendo angina, these are increasingly frequent attacks of angina. They are prolonged more than 20 minutes, and the severe angina or chest discomfort, and it is precipitated by a very low level of activity even at rest, and it is usually caused by disruption of an atherosclerotic plaque with superimposed thrombosis and embolization or vasospasm, and one half of the patients have evidence of myocardial necrosis, and in the other half MI is imminent. Now, what is myocardial infarction? It is the death of the cardiac muscle due to prolonged severe ischemia, commonly referred to as heart attack. Now, it occurs increasing with increasing age. It is 10% in less than 40 years of age and 45% in less than 65 years of age. And in gender, it is usually in the middle age. Male gender is more at risk, while the females are protected by the estrogen in the reproductive age group. In postmenopausal, due to decreased estrogen production, there is increased incidence of coronary artery disease, and it is the most common cause of death in elderly women, and hormone replacement therapy is also not protective. Now, pathogenesis. The coronary artery disease occlusion and myocardial response to ischemia leads to ischemic heart disease, and they are responsible for the clinical manifestations. It usually occurs in the following sequence. Just to revise once again, that the atheromatous plaque undergoes an acute change, hemorrhage, erosion, ulceration, rupture and fissuring, and on being exposed to subendothelial collagen, the platelets adhere, they become activated, release the granules and aggregate to form microthrombi. Vasospasm is stimulated by mediators released from platelets. Tissue factor activates the coagulation pathway, and within minutes the thrombus expands to completely occlude the lumen. In 10% cases, other mechanism may be responsible, like vasospasm, which may be with or without atherosclerosis, usually with platelet aggregation or due to a drug ingestion like cocaine or ephedrine. Then emboli may occur from left atrium in left atrial fibrillation, or a vegetation of infective endocarditis may act as an emboli, or there may be a paradoxical emboli from right heart or peripheral vein which enters the circulation from patent foramen ovale. Now, other small causes may be disorders of small intramural coronary vessels like vasculitis, hematological abnormalities like sickle cell disease, a myelin deposition, cardiac hypertrophy, shock, lowered systemic blood pressure, and inadequate myocardial protection during cardiac surgery. Now, what is the myocardial response then? When there is a coronary artery occlusion, there is a decreased supply, ischemia occurs. Due to ischemia, because there is no ATP and toxic metabolites are increased, so there is a rapid myocardial dysfunction. if the ischemia continues for a longer time, it may result in a myocyte death. Outcome predominantly depends on the severity and the duration of the flow deprivation, and the anatomical region supplied by that artery is known to as the area at risk. Now, the cessation of the aerobic metabolism within seconds leads to inadequate production of creatinine phosphate and ATP production, accumulation of noxious metabolite lactic acid, and so myocardial contractility ceases within a minute of onset of the severe ischemia. Such loss of function precipitates heart failure long before myocyte death. Now, the ultrastructural changes like myofibrillar relaxation, glycogen depletion, cell and mitochondrial swelling develop within a few minutes of the onset of ischemia. However, these changes are potentially reversible, and only severe ischemia, when the blood flow is less than 10% and it lasts 20 to 30 minutes or more, it leads to irreversible damage. This delay provides the rationale for rapid diagnosis in MI, so that early coronary intervention can be done to establish reperfusion and salvage at-risk myocardium. The earliest detectable feature of myocardial necrosis is disruption of the integrity of the sarcolemmal membrane. This disruption of the sarcolemmal membrane allows the escape of intracellular myocardial proteins, forming the basis of diagnostic blood test for MI. And these intracellular proteins can be detected very easily by blood test, so that it can be diagnosed and managed very early, and patients of MI can be saved. Okay, thank you.